Hello and welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for your interest in our Dr. John G. Bartlett Memorial Education Series. Today's program, entitled The Continuous Challenges of Non-COVID Respiratory Tract Infections, is made possible by the support of our industry partner, Thermo Fisher Scientific. To access this and other educational programs, please visit our website at idsafoundation.org. Sign up for our monthly newsletter, follow us on social media, and stay informed about the mission-critical work of the Foundation to reduce the burdens of infectious diseases worldwide. Before I introduce our first speaker, please use the Q&A button to add your questions at any point during the presentation. Now let's get started. I'd like to introduce Dr. Donna Woke. Dr. Woke is a division chief in Geisinger's Diagnostic Medicine Institute, overseeing molecular and microbial diagnostics and development. She is a professor at Geisinger Commonwealth School of Medicine and a diplomat in the American Board of Medical Microbiology. She is the founder and principal investigator for Geisinger's Microbial Diagnostics and Innovation Center. Now I turn it over to Dr. Woke.
Thank you very much for the opportunity to speak with you today. My topic is respiratory infections that are non-COVID, so somewhat of a change from our past several years. I'll be talking about screening, diagnosis, and surveillance, and starting out with screening. So screening of respiratory pathogens from the lower respiratory tract may be annoying and is sometimes misunderstood, but it does have a basis in microbial pathogenesis of the infection, and we'll be discussing that today. The examination of a gram stain smear of the specimen frequently reveals if the specimen is satisfactory, and in your laboratory reports, you'll know that that's acceptable, and we culture that sample. If it is not acceptable, then that sample is rejected and a recollection is requested. An acceptable gram stain generally contains polymorphonuclear leukocytes or white blood cells, segmented white blood cells, alveolar macrophages can be seen, and most importantly, few or no squamous epithelial cells. Now, for bonus points on a screen or a gram stain, if the organisms are engulfed or phagocytized, we can see bacteria inside the cells, that's considered a sign of infection when we see intracellular organisms, and that may be reported on your actual gram stain report. Screening assumptions with the sputum gram stain is that when you see organisms in the vicinity of or phagocytized within a white blood cell, a neutrophil, that is indicative of where the pathogenesis lies. And later you'll see that we use the gram stain to drive the culture results. Now, if someone is neutropenic and they don't have an adequate number of white PMNs, then that's not useful for those type of cultures. Squamous epithelial cells indicate superficial contamination, spit, oral pharyngeal flora, etc. And then the contamination of these samples could include certain opportunistic pathogens from the mouth that, if identified on culture, could misdirect proper therapy. Now, on the left, you'll see gram stains that are obviously acceptable. Neutrophils abound, and you see Streptococcus pneumoniae, you see Corynebacterium striatum on the top left, and on the bottom you see intracellular gram-negative rods. On the right, you see obviously rejected samples. The criteria, it may vary, but more than 10 or 25 epithelial cells can reject the specimen, and a minimum of 20 low power fields on the microscope are reviewed to make this determination. Now, I won't read through the chart. However, you can see that there's a variety of cutoffs for screening criteria. There is no standard criteria, and that becomes part of the problem of diagnosing lower respiratory tract infections. The sputum is actually the lowest quality sample that we get in the laboratory. 20 to 60% of these samples may be adequate depending on what methods used and what hospitals are reporting. Higher quality is an endotracheal aspirate, where 40 to 84 or 85% could be adequate. mini BALs and BALs, and tissue or needle aspirates. Nevertheless, sputum samples are very common in our laboratory across the United States in our laboratories. So the diagnosis of pneumonia occurs after the screening of an adequate specimen, and the diagnosis, because of reasons I suggested and other reasons, is very complicated. So on the left, we see a lower respiratory tract culture that's obviously easy. It is Strep pneumoniae with a P disc on there. It's a pure culture. And this is what people think microbiologists do in the laboratory. In reality, what we really do is pull apart messes of oropharyngeal and colonizing bacteria, trying to separate the wheat from the chaff, trying to identify true pathogens from commensal pathogens from oropharyngeal flora. And I will say that even the high quality, or in air quotes, BALs and mini BALs can have a fair share of colonizing respiratory flora. And so it's not straightforward most of the time. Now, because the Gram stain drives the culture, but there's no true reference standard, and the accuracy of the Gram stain varies widely from laboratory to laboratory, with sensitivities ranging from in the 30s to the 90s, specificities from the teens to the 85s. In general, extensive testing on 10 or 20 quality type of mixed respiratory cultures is not routinely performed. And because of this conundrum, several stain scoring systems were developed. Two of the most common are called the quality or QSTOR, that relies on higher density of PMNs and lower squamous epithelial cells, and the Q234 system that's driven by the number of organisms. Now, in general, the comparison is based on the Q score on the types of cells and the Q234 on the types of organisms that we see on the culture. And when bacteria are seen in the direct Gram stain, we know that they're there in significant numbers, and that also helps drive these scoring systems. Over 10 to the fifth, 10 to the fourth is typically in the moderate to many category when we semi-quantitate a culture. And when they're seen in association with the PMNs, they are considered to be most likely associated with the infection if there is one. And then neutropenic patients, again, cause a problem with these Q scores because there may not be the neutrophils to rely upon. So I kind of align these Q score systems to something that is seen in the wilderness called an Inukshuk. And this is a picture from Canada, where the stone people are seen in the Arctic. Is that the Q score and the Gram stain are kind of like an Inukshuk. They're pointing you in a certain direction, but it's certainly not a GPS signal. So it is a general interpretation of what you see. Now, aspiration pneumonia is a lower respiratory tract situation, and this is also based on risk factors for aspiration and clinical symptomology, x-rays, et cetera. But from the Gram stain, we can find that we have sputum indicative of aspiration pneumonia when we have mixed flora, both Gram positive and Gram negative, and they are likely to be intracellular. So many laboratories will report the fact that there's mixed flora, intracellular flora, and this may be indicative of aspiration pneumonia, which could include anaerobes and would not grow on a traditional bacterial culture. And even in chronic aspiration pneumonia, you can also see yeast in the Gram stain. So tips and caveats: if someone is too weak to cough an acceptable sputum the first time, we find in our own data that repeating the sputum is unlikely to change the rejection result. It's better to escalate and seek a higher quality specimen. Culture and PCR are more sensitive than a Gram stain by 3 or 4 logs at times. On-board antibiotics may derail the culture, so you may see it in the Gram stain, but it may not grow. You should seek microscopic areas and look for phagocytosis, and realize the Gram stain is not really applicable for poorly staining microbes, Legionella, Brucella, and uncultivable organisms like Pneumocystis viruses, which can grow in cell culture, but are basically molecular now, and mycoplasma. So you need to be looking at PCR or special culture media, special stains like carbofuchsin, acridine orange, or calcifluor white. And finally, we see the emergence of the lower respiratory tract pathogen panels. The first ones on the market associated with community-acquired pneumonia, and they have a mixture of virus infections that are common with bacteria and some antimicrobial resistant markers in general. There are several companies who sell these types of multiplex LDTs. The advantages are they're fast and they can quickly identify common pathogens with some antimicrobial resistant markers, and that may allow faster and better targeting of therapy. But since there is no standardized lower respiratory tract culture, it's hard to standardize the molecular panels. And so cost benefit questions remain. Reimbursement for these panels is tenuous, and the culture is still required because we still need to cover organisms not on the panel and if we need susceptibility. So in general, semi-quantitative results mimic the laboratory practice that uses semi-quantitative culture, few, moderate, many, 1+, 2+, 3+, 4+, but semi-quantitation occurs through comparison with a co-amplified human cell control. So there's really no measure of gram stain screening accuracy unless it's deployed by the laboratory. And some places do that, or some places will only use BALs and high quality specimens on these panels. The limit of quantitation goes from 10 to the 4th to 10 to the 7th, and a negative result is similar to a quantitative BAL where people are reporting greater than 10 to the 4th CFU per milliliter. Some studies show that these lower respiratory panels are equivalent to culture, and some show lower accuracy. And we desperately need evidence-based studies depicting the response to these actionable results so that we can move towards test reimbursement. And then finally, surveillance, to do it, not to do it, really that's the question. Whether you're going to do culture or molecular-based surveillance, active or passive surveillance, really depends on the infection prevention needs for hospital-acquired pneumonia, and non-ventilator associated pneumonia and non-ventilator associated pneumonia. And so with surveillance methods, we typically see Legionella sampling from water, which is then potentially compared with patient strains, if any, by strain typing or NGS sequencing. You can create special media that's created in batch for the pathogen that you're looking for with extra antimicrobials that will weed out the things you're not looking for. And this might occur when there's enteric gram-negative results or non-lactose fermenters like Pseudomonas or Acinetobacter. There's also chromogenic media for passive or active surveillance, and that's used for MRSA in outbreak situations, and gram-negative MDROs like ESBL Chromogar. And finally, molecular surveillance can be used, but many of these methods really are not FDA cleared, and none of them, to my knowledge, are FDA cleared for surveillance purposes. So people have to do laboratory developed tests. All right, thank you for your time. That's a quick overview, and thanks again for inviting me.
Thank you, Dr. Woke. Now I'd like to introduce Dr. Leila Hoja. Dr. Hoja is an infectious disease physician at University Hospitals Cleveland Medical Center, an assistant professor of medicine at Case Western Reserve University. Dr. Hoja currently serves as the Director of Antimicrobial Stewardship at University Hospitals and is serving on the advisory board for the 2023 ATS and IDSA Community-Acquired Pneumonia Guidelines. Dr. Hoja, over to you.
Well, thank you so much for the invitation to speak at this webinar. So I have no conflicts of interest, but I do want to mention that my part of this talk is mainly going to be focused on pneumonia. And then in terms of my objectives, these are the whole webinar's objectives, and I'm going to be focusing on part of this first bullet point, which is to understand the pathogenesis, etiology, and clinical presentation of pneumonia. So to start with pathogenesis. So it's generally thought that colonization precedes infection in the lower respiratory tract, which we know is a non-sterile site, meaning pathogens must both gain entry as well as overcome the body's natural defenses. Pathogen entry is usually by inhalation, but also can occur through aspiration, and less commonly, there can be seeding from the bloodstream. Once the pathogen gains entry, in order to cause infection, it either has to capitalize on a defect in the host defenses, or itself must be highly virulent or be an overwhelming inoculum, or can be any combination of these. Looking at host pulmonary defenses in more detail, we see that in the upper respiratory tract, the main defense mechanisms are more mechanical processes, which are very effective for larger particles. And then moving down into the conducting airways, there's still some of those mechanisms, but begins to introduce more inflammatory and antimicrobicidal components. The terminal airways have to have a more sophisticated response because most bacteria are actually between around 0.5 and 2 micrometers in size. And so they aren't going to be filtered for the most part up above here. And so, this begins with pattern recognition receptors, which then lead to an inflammatory cascade, which sometimes is enough in and of itself to deal with the pathogen, but also can recruit neutrophils and activate the adaptive immune response through memory lymphocytes. There are a number of ways, of course, that the host defenses can break down. So these are just a few examples. So altered consciousness can compromise the epiglottic closure reflex. Cigarette smoke affects the mucociliary apparatus and also macrophages. Alcohol can also affect reflexes, but also introduces colonization of more pathogenic organisms and impairs neutrophils and TNF response. HIV, of course, we think of as affecting CD4 T cells, but also affects other aspects of our immune response. Upper airway manipulation just completely bypasses your upper airway defenses, meaning something like intubation. And then age and congenital defects either cause like breakdown of the host defenses, or else never having developed those defenses to begin with. But those are just a few examples. There's many, many other examples of ways that this can break down. Some of these are structural, some are related to exposures, and some are just related to the body's overall ability to combat infection. Now, regardless of the host having an intact immune response, pathogens also might find ways to circumvent the host defenses through their virulence factors. And several of those are listed here. Strep pneumoniae in particular carries many of these types of virulence factors, and that's part of what makes it so effective at causing lower respiratory tract infections, as we'll see. In terms of etiology, so we can kind of categorize this into the setting as well as the clinical syndrome for acute pneumonia. So in the typical organisms category, we tend to think of this as like sudden onset of typical symptoms like cough, pleuritic chest pain, and there classically is a lobar appearance on chest imaging, and strep pneumoniae is kind of the most common pathogen that we associate with that. We tend to put viruses and Mycoplasma, Legionella, those go into the atypical category usually, and this may have a more varied clinical presentation, and chest x-ray typically is more patchy, but just to be aware that these aren't always very clear-cut distinctions. Now, CAP can also, community-acquired pneumonia can also be associated with more resistant organisms, depending on prior exposures and things. So Staph aureus in particular is quite virulent, coming in from the community, even more so than we often see in the hospital setting. And then hospital-acquired and ventilator-associated pneumonia, again, we think of oftentimes more resistant pathogens, but also just that generally the nosocomial flora that we see is unique and not seen with maybe other aspects. In terms of prevalence of CAP. So first, it's just important to recognize that for the most part, we don't actually get a definitive diagnosis. We're either treating empirically or testing didn't come up with an organism. But in any case, for the cases where we do have an identification, so in the US, about a quarter of our cases of overall pneumonia tend to be caused by viruses, and that's sort of the majority. And that would be rhinovirus and influenza. And then about 10% of cases, and more like a quarter of cases in European countries, tends to be bacterial. And you can see by far this is strep pneumo is the most common here. Now, it is important to recognize that strep pneumo has consistently decreased in prevalence in the US over time, and that is mainly due to vaccination. And then all of this can vary by age group or the season or geographical location. There are many other etiologies of acute pneumonia that can occur based on specific risk factors, whether these are zoonotic risk factors, whether the host is immunocompromised, travel related, or other specific environmental components, which also may be related to animal exposure as well. Then there are a number of organisms and pathogens that we tend to see in a more subacute or chronic pneumonia type picture. And these are often, again, related to endemic areas or the host having an being immunocompromised. Then for clinical manifestations, so of course we think of things like cough, sputum production, dyspnea as being associated with pneumonia, but it's important to recognize that it can have actually a very varied appearance, and it's hard to pin it down based on any one factor. Notably, absence of any vital sign abnormalities has a high negative predictive value. And then there are some uncommon findings that do have a high positive predictive value if you do see them. And then, of course, we have a number of imaging and also lab modalities that can be helpful in terms of directing our therapy and helping kind of confirm our thought processes about the diagnosis. But it's really important to recognize that pneumonia really is truly a clinical diagnosis. You can have a number of complications that develop, and that might be due to just severe infections that kind of progress or remain established. And you can have chronic infections that then lead to other issues. And oral health is actually a big factor here in terms of development of complications. And then finally, there are a number of conditions that can mimic pneumonia that are not infectious. And so it's important to think about these and try to rule these out, as none of these, for the most part, would need antibacterial therapy and may need some other different types of management. So to conclude, pneumonia occurs via exploitation of defects in host defenses, high organism virulence, or overwhelming inoculum. Pneumococcus is the most common bacterial cause of pneumonia and has been decreasing in prevalence in the US. Viruses are the most common overall cause of pneumonia in the US, and pneumonia, above all, is a clinical diagnosis. And that's all I have, and I'll turn it back over to Diane.
Thank you so much, Dr. Hojat. Now I'd like to introduce Dr. Mary Rose Lagiovilla. Dr. Lagiovilla is an infectious diseases physician and chief of the Infectious Diseases Division at Rochester General Hospital in Rochester, New York. She established and is the medical director of the RGH Antimicrobial Stewardship Program and the physician leader for developing the Rochester Regional Health System Hospital Stewardship Collaborative. Dr. Lagiovilla serves on various hospital and system-wide committees, striving to promote the appropriate use of antimicrobial agents through clinical stewardship, interventions, program and guideline development, and active research. Dr. Lagiovilla, over to you.
Thank you for that introduction. I'm honored for this opportunity to participate in this webinar, and my portion will focus on when to see a healthcare provider when one has a respiratory tract infection. And I'm also going to discuss the antibiotic decision-making involved in these conditions, as well as the importance of vaccines and vaccine-associated immunity when it comes to respiratory tract prevention. First off, I have nothing to disclose, but I feel strongly that I should professionally disclose that I am an avid antibiotic steward. So in approaching this topic, I felt it was important to illuminate the additional current challenges in antibiotic prescribing in this arena. And antibiotic use, especially in respiratory tract infections, is a big interest of mine because it's a condition that gets a lot of antibiotics, and there's many opportunities. So I'm sure those of you who attend this webinar are very familiar with the fact that most upper respiratory tract infections do not need antibiotics. And for that, fortunately, we are not alone. The American Board of Internal Medicine Choosing Wisely campaign highlights the recommendations of the IDSA and several other professional societies, including the American Academies of Pediatrics, Family Physicians, Head and Neck Surgery, and Allergy, Asthma, and Immunology, who similarly all recommend against the routine use of antibiotics in these conditions. And between us and these other societies, it seems to me that all people across the spectrum should be covered with no mixed messages. And yet, somewhat disappointingly, antibiotic prescribing continues to be quite a challenge. Just a few months ago, a descriptive study published in OFID reviewed the antibiotic prescribing practices among primary care providers in a large health system in the upper Midwest. This included over 95 clinics and over 5,000 primary care providers. Reviewing nearly 50,000 patient encounters, they found that overall antibiotics are unnecessarily prescribed 42% of the time. So despite the Choosing Wisely campaign and other public health initiatives, antibiotic overuse continues to be very common. And if we're going to put a monetary value on the volumes of this waste, another study by Butler and colleagues looked at national level attributable expenditures to inappropriate antibiotic prescribing. Looking across 2.8 million outpatient pediatric encounters, this amounts to more than $65 million per year purely in just the pediatric population alone. So it's important to stress that, as Dr. Hojat had mentioned, that viral etiologies are the most common causes of respiratory tract infections in general, both upper and lower. So undoubtedly, contributing though to this is that it still remains very difficult clinically to tell if someone has a respiratory tract infection that is bacterial or viral in origin. And my predecessors discussed, there's progress and improvements in diagnostics, but this has not completely eliminated the challenge. And mainly because there's significant overlap in the presentations, that certain signs and symptoms can be very similar, but I think that there are a few that we should be aware of as healthcare providers that we can educate our patients that they may be signs of a progressive infection or of the presence of a bacterial co-process. So these are listed on the left, and primarily they are involving a worsening or a longer term continuation of more than 10 days of their symptoms, because a long duration such as this may be unusual for a virus. If there is a double sickening, wherein symptoms seem to initially improve, but then recur with new onset of fevers or worsening headache or respiratory symptoms. If they have any other signs of potential lower respiratory tract involvement, whether it's increasing severity of breathing, or difficulty breathing, or increased frequency and severity of coughing, or if they hear some wheezing. Also, if they feel dizziness or loss of consciousness, this may be related to decreased oxygenation or lower blood pressure related to secondary bacterial pneumonia. So if any of these warning signs emerge, it'd be advisable to go see a healthcare provider so they could do a more complete evaluation for additional objective markers of infection. Again, as the doctors before me had mentioned, pneumonia is a clinical diagnosis, and it should be a combination of the patient's symptomatology as well as objective markers of infection, such as leukocytosis or abnormal breath sounds on exam, as well as new radiographic changes, because there are many conditions which may meet one or two of these criteria, but they don't need necessarily antibiotics, or they're due to other non-infectious conditions. But if bacterial pneumonia is diagnosed, there are clinical prediction models that are advised to use because they can help in triaging the patients. These clinical prediction models include the Pneumonia Severity Index, which is on the top, or the CURB 65 Index, which is on the bottom. They have been evaluated extensively, and while there's no significant differences noted in the overall test performances, you can see that the pneumonia severity index may be a little bit more challenging to use routinely because it does pull in more specific patient information and is just more complex in general. Whereas the CURB 65 being an acronym is a bit easier to use and remember. So again, using these clinical prediction scores, it can help providers decide on what the best triage location is for their patients. And subsequently, based on the triage location for the patient, the antibiotic regimen is different. So again, people who have lower scores and have a lower risk of death, they may be treated as an outpatient. And those who have very high scores, they probably have more severe pneumonia, have a higher risk for mortality, and therefore should be admitted to the inpatient setting and possibly into the ICU. And based on these triages, different antibiotic regimens are suggested by the 2019 IDSA and American Thoracic Society CAP guidelines. Patients triaged to the outpatient setting with no comorbid conditions are likely low risk for drug-resistant pneumococcus, and thus monotherapy with any of the listed agents is recommended. But for those with chronic heart or chronic lung or chronic kidney or other concerning medical conditions, even if the PSI score is low enough to be triaged to the outpatient setting, dual therapy is recommended. This population is more likely vulnerable to poor outcomes if their initial antibiotic regimen is inadequate, or these conditions may make them more often exposed to healthcare settings and or prior antibiotic exposure, increasing their risk for penicillin-resistant pneumococcus, and thus the dual therapy. For patients sick enough for admission to the hospital but not needing ICU level care, coverage for the most likely pathogens, including the possibility of penicillin-resistant pneumococcus, is recommended, as noted. And please note that the respiratory quinolone should be reserved to patients with true and severe beta-lactam allergies. Finally, those with severe infection warranting ICU admission, dual therapy with the listed regimens are up there. I'd like to add, and I saw this as one of the questions in the chat, when should you be concerned for MRSA or Pseudomonas, and should this coverage be instituted routinely? I'd like to, and there's not enough time in this webinar, but I'd like to highlight the GLIMPS study. The reference is on the bottom left. It was published in Lancet ID in 2016, and it was a global initiative to really try and outline what is the incidence of MRSA in community-acquired pneumonia. And after collecting data on thousands of patients, they find that the incidence is quite low, like single digits, and it varies by geographic region, but it fortifies that the likelihood of MRSA in general is low. They do illuminate that there are certain risk factors to be conscientious of, such as if someone has previously had MRSA on a colonization test or in prior infections, or if they have a history of recurrent skin and soft tissue infections, they may have a higher risk for MRSA. Similar, the same group did subsequent microbiologic reviews on the incidence of Pseudomonas involvement in community-acquired pneumonia, and they again also did risk factor analysis to see what would be the most likely patients which would have a higher incidence of Pseudomonas. And these are individuals who have known chronic structural lung disease, such as cystic fibrosis or very bad COPD, or have indwelling tracheostomies. So the GLIMPS study, I think, helps become more fine in your antibiotic decision-making. And if your patient in front of you coming in from the community does have these risk factors, of course, consideration of adding respective coverage is warranted. There are newer agents in the last few years for community-acquired pneumonia, and they're listed on the bottom in the red. At this time, their place in the treatment spectrum is still being evaluated. Antibiotic duration. I do want to take a moment to focus on antibiotic duration because sometimes in antibiotic stewardship, it's a bit of an orphan detail in the antibiotic plan. I'm sure we've heard the joke that, antibiotic durations follow football scores or ranges. It's like 3 days or 5 days or 7 to 10 days, 10 to 14 days. And in the IDSA guidelines, we really strive to be more specific. And I think there is wonderful opportunity to educate providers across the healthcare spectrum that the recommendation in community-acquired pneumonia is if your patient achieves clinical stability, 5 days can be enough. Yet despite this, in a cross-sectional study published in JAMA across 192 hospitals, they found that not only were patients being treated inconsistently with the guidelines, the most common reason was because they got excessively long antibiotic durations. The median duration time was 10 days. So we could cut our antibiotic use as a nation in half for community-acquired pneumonia if we started to be more guideline congruent. If there is a drug-resistant organism, such as MRSA or Pseudomonas, then the duration of therapy that's recommended by the guidelines is 7 days. And I think what's interesting is that recently there's been a publication of a double-blind placebo-controlled trial of hospitalized patients looking to see in patients who are clinically improved by 48 hours, could you treat them with just 3 days alone? And they were compared to individuals who received a total course of 8 days. And the results found that it was non-inferior to receive a shorter course. So duration, I think, is a great opportunity for more improvement in our antibiotic use. And, sometimes on stewardship, we get this pushback of it's just a day of antibiotics, as if there's no harm. But we really should be aware that there's more and more data that, in fact, every antibiotic day counts. One meta-analysis found that every additional day of an antibiotic was associated with a 4% increased odds of having an adverse drug reaction. Another large study coming out of the VA system, looking at surgical prophylaxis antibiotics, which are meant to be ultra short courses of often a single dose or a day. Despite these recommendations, they commonly receive longer antibiotic courses with the perception that this will reduce the incidence of surgical site infections. Well, interestingly, the authors across nearly 80,000 surgical patients found that not only did longer durations not reduce the incidence of surgical site infections, it actually increased the chances of them having acute kidney injury and C. difficile infection. So in fact, every day counts. Shifting gears, I'm going to briefly touch on the role of vaccines, which may be best summarized by this Benjamin Franklin quote: "An ounce of prevention is worth a pound of cure." And vaccines play a critical role in community health as they can prevent the incidence and spread of these respiratory tract infections. Now, there are a number of vaccines currently available targeting respiratory tract pathogens that are listed on the left. To highlight their impact on disease, I'm just going to briefly talk about the pneumococcal vaccines. So currently there are two types of pneumococcal vaccines available in the US, a polysaccharide and a conjugate type. And while there are more than 90 serotypes of pneumococcus, the active components of both vaccines target the specific pneumococcal serotypes known to more commonly cause invasive disease. And in general, in thinking about the impact of vaccines to the vaccine recipient and the recipient's community, there are many complex layers that deserve a webinar of its own. But the overarching goal of pneumococcal vaccination is to stimulate effective anti-pneumococcal antibodies, as well as mucosal immunity. So there's an immunological memory and prevent disease. And in addition to this, there are also fortunate ripple effects. So for the vaccine recipient, the direct vaccine-induced immunity is related to it stimulating B cells to make capsule-binding antibody. And this capsule-binding antibody is important for acknowledgement of the initial infections. They're also stimulating to make mucosal IgA, which importantly prevents nasopharyngeal pneumococcal colonization, and to some degree also reduces nasal carriage rates. The vaccine also stimulates host T cells that make cytokines, which augment B cell responses and promote a longer lasting antibody response. And because of this, if infected, and we've seen this also with other vaccines for respiratory tract infections, people who are vaccinated tend to have, if infection, they have milder disease. So they often have less symptoms that could produce the aerosols transmitting the infection to others. They also have a shorter duration of symptoms, which reduces the window of opportunity for community spread. And ultimately, this decreases the probability of secondary transmission from vaccine recipients to others. And last, very importantly, because vaccines reduce the nasopharyngeal carriage of vaccine-type strains of pneumococcus, this in turn reduces transmission to others, especially those who aren't immunized. So this contributes to herd immunity. The CAPITA trial, I'll highlight here, which was published in NEJM in 2015. It was a large study that enrolled over 85,000 adults and was placebo-controlled in patients ages greater than 65 years. And it really wanted to demonstrate that in older individuals, how the conjugate PCV13 vaccine was effective in reducing the incidence of vaccine type non-bacteremic, non-invasive CAP and invasive pneumococcal disease. But you can see that really a bigger story is told when you look at the impact of pneumococcal vaccines in children. So there's an impact, a temporal trend of the impact of vaccinating children on the incidence of adult pneumococcal invasive disease. So you can see this timeline across the decades. There's a steady decline in the incidence of adult invasive disease that was related to widespread vaccine campaigns in children. Noteworthy, though, is that the ACIP, the Advisory Committee on Immunization Practices, currently recommends vaccines for adults over 65, and if adults are younger than 65 with certain immunocompromising medical conditions. However, despite this, adult vaccination rates remain low, and we should do better than that. So in conclusion, most respiratory tract infections are viral and don't need antibiotics. There are several key symptoms for which we can be mindful of and educate our patients of when to seek medical care. And if antibiotics are indicated, regimens vary based on disposition, the severity of the pneumonia, the likelihood of involvement of a drug-resistant pneumococcus. And last but not least, of course, vaccines are incredible tools to prevent severe respiratory pathogen infections and reduce the incidence of disease. Thank you, and I'll pass that back to the host.
Great, thank you so much. And thank you to Doctors Woke, Hoja, and Longiovilla for your insightful presentations. I don't know about the rest of the audience, but that was an incredible amount of information in the last 45 minutes. Before we get to some of the questions by our audience, I do have an exciting announcement. In addition to this program, Thermo Fisher Scientific will soon be providing the first 100 registrants access to the IDSA Core Antimicrobial Stewardship Curriculum through an educational grant. We will officially announce this grant opportunity next month during ID Week, so be sure to check our website after October 18th if you're interested in being one of those people to get the educational grant. If you haven't already submitted questions, again, please use the Q&A button to do so. But we do have a few already. So let me just get to those questions. One of them is certainly about a recording. Yes, this program is being recorded. We do record all of the webinars that we do. It will be available on our website within 2 to 3 business days after this. So just give us a little bit of time to clean this up, but it will be available on our website at idsafoundation.org/your-health. Again, you can reach that, and you can also look and see prior webinars as well if you're looking for other valuable information. So for the speakers, these are in no particular order, so I'll let you guys kind of come on screen and answer the questions for those that's appropriate. What I have here is, what is the single most important statement that can convince hospitals from prescribing broad spectrum antibiotics? For example, Zozin, Z-O-Z-Y-N, plus or minus, and I'm going to butcher this, vancomycin for patient presenting with presumed LRTI infections, including presumed aspiration pneumonia. We have struggled with reducing the Zozin Vanco for presumed pneumonias.
I'll take a stab at this answer, and I'll say that my institution has a similar challenge. So I think I was able to include 2 studies that highlighted the infrequent incidence of MRSA and Pseudomonas in community-acquired pneumonia infections. Also in those studies, they analyzed what kind of patient characteristics were associated with having those pathogens. So for us at our institution, we try and educate our frontline providers to consider whether or not the patients have those kind of conditions that would justify starting those vancomycin, the empiric antibiotics to cover those drug-resistant pathogens. But in conjunction, and this is aligning with the IDSA community-acquired pneumonia guidelines, that an adequate microbiologic evaluation upon initiation of antibiotics is critical, because it's one thing to start a regimen, but you do need to try and have an exit strategy. So that way, as you have diagnostic workup coming back, and whether it'll include, and maybe Dr. Woke could speak more about this, versus surveillance, which is a surveillance test of the NAIRS that has been shown to have pretty good negative predictive values for an absence of MRSA in the lower respiratory tract infection, lower respiratory tract. If you could include that in your evaluation for patients that you choose to start empiric vancomycin or empiric MRSA coverage. Similarly, unfortunately, we don't have a surveillance test for Pseudomonas, but that's where the sputum sample becomes so critical. The patients who are more likely to have Pseudomonas involved tend to seem to have structural lung disease or chronic bronchiectasis or tracheostomies, and these tend to have a lot more productive sputum. So hopefully they would also be able to access that sputum to do the full microbiologic workup and either confirm or confirm the presence or absence of Pseudomonas to allow de-escalation later.
Dr. Woke, did you have anything to add to that?
So the literature does show the correlation that was just discussed. However, I personally don't know any infection prevention practices that are specifically screening for lower respiratory tract. There are folks performing active surveillance of the nares and for certain conditions, cardiac high intensity infections like ICU. Some people do the whole house, inpatient house. Some people do pre-surgicals for heart and hip infections, and those practices are more about, self-infection and isolation practices for infection prevention than specifically targeting lower respiratory tract. But never say never, I think, in microbiology. So if there is some type of issue, it's likely that there are either augers and certainly molecular tests that can be used for active surveillance. And the practices I know about for lower respiratory tract are more associated with passive surveillance, where there's an infection and those infections are monitored with some type of a software, and upticks are investigated in hospital-based outbreaks if they occur, and that's what I know from the laboratory side.
I'll add to that as well. I think the surveillance testing that you were just mentioning, Dr. Woke, it's important to know that specifically for CAP and HAP as well, that having a negative MRSA NARES, it has a very high negative predictive value. So meaning that if you don't detect it there, you can basically use that as a means to be able to stop that coverage. And that's one of the things that we've tried to do at my institution. The other things that I just try to tell people about in general about MRSA and Pseudomonas, other than that, they're way less common than we think they are, at least for CAP. They're not subtle. They're not subtle diseases at all. So that could clinically, that's the case. So these patients are usually very sick, and then diagnostically as well. So if encouraging testing is really important, because if you don't find MRSA or Pseudomonas there, it's not there. Like they're very easy to pick up, and so those are some of the things that we try to educate people about to help them with that.
Oh, great. Thank you so much for that. And there are two other questions Is there a clear way to distinguish between viral and bacterial pneumonia? And Dr. Wolk actually typed out in the questions, but just in case participants aren't following along there, said that there are some new biomarker assays, protein-based and gene-based, and 2 are FDA cleared.
Yes, there are some gene expression assays that provide risk scores that are associated with either systemic bacterial infection or systemic viral infection. And there is a protein-based assay that also provides a risk score to the same, bacterial versus viral. The generic term for these new emerging assays is like bacterial versus viral or BV assays. But that you'll be seeing more and more of them enter the marketplace in the laboratory shortly. The other question, if you don't mind, since I'm on, there was a question that culture and PCR are more sensitive than gram stain, and that is true, while some multiplex panels are lower in accuracy than culture. And that, when I'm talking about PCR, I'm talking about singleplex PCR. So because of the massive multiplexing capabilities of the panels, not all, but some of the targets may be less sensitive than culture, depending on if you're doing broth-enriched culture or not. So broth-enriched culture and PCR, single target PCR, are generally equivalent, but you do have to be careful about some of the multiplex panels and look at their lower limit of detection compared to what you know about the culture accuracy and limit of detection. And normally your laboratories will parse that out for you and put comments in your panels so that you're aware of it. I mean, we don't expect you to look up every product insert. So that's an expectation the laboratory would give you.
And the last question I think we have is, are different organisms involved in pneumonia caused by aspiration?
Yes. I mean, community-acquired pneumonia has its hit list. All of the pneumonia types will have that, but in particular, aspiration pneumonia is noted for anaerobic organisms, and you know, those are not normally always covered. So that's the kind of comment we'll put on that kind of gram stain, just to alert people. We don't normally do anaerobic sputum cultures or even lower respiratory, because there's so many anaerobes colonizing the respiratory tract. All the way from the mouth to the gut, you will have anaerobes as the predominant organism, and they're not cultured for, except for certain situations where we may get aspirate, transtracheal aspirates. And so the gram stain is sort of an inukshuk of the aspiration pneumonia world, kind of pointing you to, you know, that there's might be something different going on than the traditional pneumonia.
Also, though, I'll mention that some of those anaerobes are still like oral anaerobes, which a lot of your standard coverage is still going to get. And so, and we see some of the kind of more, you know, like anaerobes that aren't necessarily covered. You know, we used to maybe see that more in like longer term, like lung abscesses, like kind of more complex infections like that. So usually your coverage up front will still get most of those organisms. And the most, you know, it kind of I think practice is very, you know, we don't recommend changing coverage specifically for aspiration. And I think the most recent guidelines also kind of suggest not adding additional anaerobic coverage.
Great. Well, I think that concludes the Q&A section for today. So in closing, I have just a program note. Thank you again so much to all of our speakers and to you, our audience, for attending today's program sponsored by our industry partner, Thermo Fisher. We hope you benefited from today's program. If you want to learn more about respiratory tract infections, please visit the link in the chat that will direct you to the PACE approved respiratory tract infection learning guide provided by Thermo Fisher Scientific. And lastly, if you'll be at ID Week, the foundation will host its first in-person program of the Bartlett Memorial Education Series on Tuesday, October 18 at 6:30 p.m. And that program is on PrEP implementation in primary care. Thank you all so much and have a wonderful rest of your week.